So I'll be discussing 7 syndromes with you here. These syndromes are discussed in separately in medicine also, but let me just lay more anatomical foundation to that. We'll be discussing one syndrome called as a medial longitudinal fasciculus syndrome or internuclear ophthalmoplegia. Then we'll talk about 2 syndromes from midbrain, 2 from the pons, and 2 from medulla oblongata. And see, the reason for discussing these syndromes in a pictorial manner is so that you can also understand that what major nuclei and tract are present in which part of the brainstem. Just purely drawing the sections of the brainstem and trying to remember that this is a nucleus there, that is a tract present there, lemniscus is present here. It's very boring and you know we tend to forget that. But if you remember it with a clinical correlation, like from the syndrome point of view, you'll find it interesting also, and you can remember it for long. So first in this sequence, we'll talk about the MLF syndrome. MLF. What is MLF? Medial longitudinal fasciculus. There is a white matter bundle. It's a very thickly myelinated tract present in the midline of brainstem. We'll see the function. That is called as medial longitudinal fasciculus. So either you call it medial longitudinal fasciculus syndrome, or it is also referred as internuclear ophthalmoplegia. Internuclear ophthalmoplegia. So let's talk about it. Okay. Now, what we need to understand from the visual muscles pathway and the muscles here is that let's take an example. If you want to look toward one side, if I want to look toward the right side, obviously my right eye will go for the abduction because my lateral rectus will take the eye to the other side. So my brain has stimulated the lateral rectus muscle through abducent nerve, and obviously the right eye is abducted. But on the other hand, the left eye is going for adduction. Along with the left eye, right eye, the left eye is also moving, but that is moving in a different direction. For that, it is a different direction. It is coming for the adduction. One eye is going for abduction, for which we have a different nerve and different nucleus. Other eye is coming in the adduction. That is, for that again we have a different nerve, the oculomotor nerve, and different nucleus. So the 2 nucleus, like 3rd nucleus and 6th nucleus, they're in the different part of brainstem. These different nerves supplying different muscle, how they're coordinating with each other. Because my brain only gave the order to look toward one side, and automatically it's not only one lateral rectus, the opposite side medial rectus also started working. So let's understand that pathway first, and then from there on we'll see that how it will be disturbed. So guys, let's say this here is the midline. Imagine you're seeing it from the top. You're imagining this from the top here. So let us take a cross section exactly at the level of eyeball. If you imagine a cross section at the level of eyeball and you're seeing it from the top, you're seeing it from above. Right. So the muscles will be like, this is medial rectus, which will be pulling toward the midline for this and this as well. This is medial rectus. And here we got lateral rectus for the abduction. Now let me start from this side. Let us say the cerebral cortex of the right side. If I say this is cerebral cortex of the right side, will give the upper motor neuron. Upper motor neuron are the one which decussates. There are some nerves in which the lower motor neuron were decussating, like trochlear nerve, the lower motor neuron were decussating. But for most of the nerves, upper motor neuron decussate. So from the cortex, the upper motor neuron will come to the contralateral side. Let's say they are stimulating the abducent nucleus. Where was the abducent nucleus? In the pons. The abducent nucleus. And the abducent nerve will go and supply what muscle? Lateral rectus of the same side. That is abducent nerve. That is abducent nucleus, and that is nerve supplying lateral rectus and obviously resulting in the abductions. If I just show you the eye from the front, so that is what is happening here. The abduction is taking place. The main question is why medial rectus of the other side is adducting where the cortex is not directly stimulating it. cortex has stimulated 6 nucleus only. But what you'll see that from the 6 nucleus, there are some connection going to the opposite side, third nucleus, which is in the midbrain. From where the third nerve is coming out, we know the third nerve is the one which supplies medial rectus, and that is the one responsible for the adduction of this eye. This is the third nerve, obviously from the third nucleus supplying medial rectus. So you can see one eye is getting abducted, one is getting adducted. But still the question is how they are connected. So there has to be something in the brainstem in the midline, close to midline, which is connecting the nucleus of the opposite side. And that is what you call as MLF, medial longitudinal fasciculus. Medial close to midline, longitudinally arranged in the entire brainstem, and fasciculus means white matter bundle. So guys, we have this MLF. Let's say this is the MLF here. And this MLF is the one which the white matter bundle. These nucleus are very close to the midline only, right? So this is just schematic diagram shown like this. So we have a, like if there's an MLF here, so the fibers through the MLF will go on the other side and connecting into the third nucleus of the other side. Now our question is about MLF syndrome. If this medial longitudinal fasciculus is injured, if there is a vascular lesion or any other reason, if the MLF is injured, so the connection between the 6th nucleus and the 3rd nucleus will be lost. If the injury is to the MLF, then obviously the connection between the 6th and the 3rd nucleus will be lost. And that's the reason we call it internuclear ophthalmoplegia, because the connection between the two nucleus is gone. So internuclear ophthalmoplegia. So in case of syndrome, if there is an injury of this MLF, now what will it lead to? Now, if now the cortex will stimulate the lateral 6th nucleus, which can be done, you can see this pathway is still intact. That pathway is still intact, your lateral rectus will be abducted. So this one side lateral rectus is abducting, the one which you want to, the side you want to look at. But because this MLF is not intact here, so the connection is lost, and therefore the 6th nucleus will not be able to stimulate the 3rd nucleus, which in turn will not be able to stimulate the medial rectus, and there will be no movement in that eye during abduction, and that will stay in the midline only like this. So it's like you're trying to look at one side, so only one eye is going for abduction, but the other eye stays in the midline only, because the connection between the 6th and 3rd nucleus is lost. And this is what you call as the MLF syndrome or internuclear ophthalmoplegia. MLF syndrome or internuclear ophthalmoplegia. But there's another important feature to be noticed. You must have seen that the patient with the internuclear ophthalmoplegia, when you ask them to abduct, so when they do the abduction, not only this eye is in the midline, the eye which has abducted also shows nystagmus. Horizontal nystagmus is also there. Well, why it is so? See, what cortex will do, cortex will try to overstimulate the 6th nucleus because this connection is lost. So cortex is trying to like compensate for it. That is the property of the cortex for the central nervous system. When it is not able to stimulate a particular muscle or nerve, it starts to fire over and over again. So cortex will fire over and over again, and that will stimulate the 6th nucleus repeatedly. Still nothing is reaching the other side. But because of repeated stimulus of 6th nucleus, your 6th nerve and this lateral rectus will be stimulated over and over again, and that will cause the horizontal nystagmus also. So it's basically a compensation which brain is trying to do by trying to overstimulate that nucleus, and that is causing the horizontal nystagmus. In this eye only, the one which is moving. So there will be horizontal nystagmus also. You can note that horizontal nystagmus is because of what? Horizontal nystagmus is because of the overstimulation of 6th nucleus as a compensatory mechanism. It's a kind of compensation which cortex is trying to do as a compensatory mechanism. The overstimulation of 6th nucleus will be there, and that causes the horizontal nystagmus. So that is the first one, guys. This is about the internuclear ophthalmoplegia, or also called as MLF syndrome. Now from this, let's move on to the transverse sections of the brainstem, where we'll be talking about the syndromes here. So first we'll start with the midbrain. We'll take 2 syndromes in the midbrain, 2 in the pons, and then finally 2 in the medulla oblongata. So we're going to start with the midbrain syndromes first. So let's try to draw it the way it looks like, the midbrain. Here we go. This is the transverse section of the midbrain. And let's presume the section is taken at the level of the superior colliculus. This is taken at the level of the superior colliculus. You already know the parts of the midbrain, so I don't have to tell you again that. That is, we have a tectum, tegmentum, and the ventral part is the crus or cerebral peduncle. See, one hint lead to another. The section is taken at the level of superior colliculus. So obviously, which cranial nerve nuclei we expect to see here? Third nucleus. Third nucleus is at the superior colliculus. Fourth was at the level of inferior colliculus. So let us say this here is a third nerve nucleus. Obviously, Edinger-Westphal will also be there. So I'm simply saying third nucleus is there. So we'll see a third nerve, and we also discussed that third nerve will be coming out of interpeduncular fossa. When we discussed the interpeduncular fossa, we saw it was one of the content. So third nerve is one of the content of interpeduncular fossa. Right? Now there's a good question coming up here. We got 4 lemniscus, but out of 4 lemniscus, there is one lemniscus which you will not be able to see at the level of superior colliculus. Now think about it. There are 4 lemniscus, but when lemniscus cannot be appreciated at the level of superior colliculus, and the answer is hidden in the discussion of this pathway we did, that is the auditory pathway. Now look at this, guys. Auditory pathway was forming lateral lemniscus, and what you saw, that lateral lemniscus was reaching the inferior colliculus and then turns into the inferior brachium and goes into medial geniculate body. It will never reach the colliculus which is above it. Rest all the lemniscus will go there and then higher above. But auditory pathway is the one, the lateral lemniscus is the one which will go to inferior colliculus and turns into the brachium and goes separately into medial geniculate body. So you can note that the only lemniscus not to be seen at the level of superior colliculus is lateral. That again could be a question here. The lateral lemniscus is the only lemniscus which is not seen at the level of superior colliculus. Rest, all 3 will be seen here. You will see rest of the 3. You will see medial lemniscus, trigeminal, and spinal also. You will see spinal lemniscus there, the trigeminal and medial lemniscus, but what is not there? Lateral is not there. Make sure you write it, that lateral lemniscus is not present at the level of superior colliculus. Had it been section at the inferior colliculus, then you'll be able to see all 4. Now, we already said the reason we call it cerebral peduncle, because the major descending tracts coming from the brain or cerebrum are present here. That's why the name is cerebral peduncle. Out of which the middle part of the peduncle, the middle region of the cerebral peduncle, is holding pyramidal tract or corticospinal tract. This is where the pyramidal tracts are present. This is where the pyramidal tracts are present. So corticospinal tract are present here. See, it is midbrain. So you will be having the pyramidal tract running, then pyramidal tract continuing in the pons, then in the medulla, and in the lower medulla they will decussate. The lower medulla they will decussate. Whereas the medial part of this peduncle are having frontopontine fiber. Now, it's a very broad term when you say frontopontine, from the frontal lobe to the pons. Let's try to narrow it down, guys. Frontal lobe is a motor cortex. We have a motor cortex in frontal lobe. And to the pons, frontopontine. Pons where we have what? Pons where we got the most important nucleus in the pons is facial nucleus, motor facial nucleus. That means when I say frontopontine fiber, so in those frontopontine fiber, we also have upper motor neuron of facial nerve as well. Frontopontine, from the motor cortex to the motor nucleus of the facial nerve. So you can say that we have frontopontine fibers here. And the most important frontopontine fiber is the upper motor neuron of facial nerve situated in it. Upper motor neuron of facial nerve is situated in it. Now we can definitely add more details to it. There's substantia nigra there is red nucleus location, and pretectal and whatnot. I mean, we can keep on superior cerebellar peduncle, but we need to keep it less only. See, less is more. If you try to put all the structures of the midbrain here, then it will be difficult for you to identify that which syndrome, what structures are affected. So keep it limited and look at only those structures involvement which will give you a specific feature of that syndrome, and that can help you to differentiate between the two syndrome. When you compare it, it should be helpful in the differential diagnosis. There is no point in writing like if there are 10 features of one syndrome, you write all 10. That's not the case here. So a syndrome which will be affecting all the three, look at this, all the three lemniscus along with third nerve. So this basically affecting the core of the midbrain. The central part of the midbrain is being affected in this syndrome. So all the three lemniscus are gone and third nerve is also involved. Important thing is third nerve is also involved. And another syndrome we'll talk about in which again third nerve is involved, but this time the anterior medial part of the cerebral peduncle. Anterior medial part of cerebral peduncle, including the pyramidal tract. But again, the important thing is third nerve is affected in this case also. These are the two syndromes we're going to talk about. I want you to first highlight these regions. The three lemniscus, all the three lemniscus there along with third nerve, and here again third nerve will frontopontine fiber and pyramidal tract close to the midline. Well, again, guys, these are not the only structures involved in these particular syndrome. There are other things also, but I'm just looking at the one which are going to help us in identifying that the main features of the syndrome. Like the one I highlighted in yellow, that syndrome is called as the Benedict's syndrome. That is called as a Benedict's syndrome. And the one in the blue is very, very important from the exam point of view. That is the Weber's syndrome. Let me use the same highlighter. That is the Benedict syndrome, and this is the Weber syndrome. If I first look at that, what blood vessels are involved, involvement of which artery leads to this Weber's or to the Benedict? Well, both are by the posterior cerebral artery. If you remember, basilar artery was dividing into the posterior cerebral artery, and that is the portion which supplies the cerebral peduncle or the midbrain part. But to be more precise, the artery which is involved in the Benedict syndrome are the perforating branches of PCA. Perforating branches of posterior cerebral artery. Remember, posterior perforating substance. So those are the branches of posterior, posterior cerebral artery are going through that posterior perforating substance and supplying the central part, the core part of the midbrain. So perforating branches of PCA, and the artery involved in this case in the Weber syndrome is the major artery, is the main posterior cerebral artery, the main trunk of posterior cerebral, the proximal part of posterior cerebral. You can say the proximal part, because distal part will go and supply the cerebrum. That's a midbrain we are talking about. What are the features you will see, guys? In Benedict syndrome, there is involvement of all the three lemniscus which are present at this level. There is no lateral lemniscus, but rest of the three are there. So there is an involvement of medial lemniscus, number 1. There is involvement of the spinal lemniscus, number 2. And there is involvement of the trigeminal lemniscus, number 3. Along with what nerve? Third nerve is also affected. So your feature are mainly because of these 4. I keep on saying this mainly because there are other things also. If you read book of medicine, they say even superior cerebellar peduncle can be involved in this. That can lead to ataxia also in this syndrome. But again, that probably will not help you in differentiating this syndrome from the other one. Now, what was the effect of injury to medial lemniscus? If we just discussed that, medial lemniscus means dorsal column tract is gone, anterior spinothalamic tract is also gone. So there will be contralateral loss of conscious proprioception and etc. I'm not writing everything. Conscious proprioception, the touch, vibration, stereognosis. Spinal lemniscus, there will be contralateral loss of pain and temperature from the body. But the next line says trigeminal lemniscus is also gone, so there should be contralateral loss of pain and temperature from face also. Yes, there will be contralateral loss of other sensation from the face as well, including pain and temperature. So it's easy to compare the pain and temperature. That's why I only wrote pain and temperature. And third nerve injury, again something we have discussed in the cranial nerve. Third nerve injury will lead to, what are the features, guys? LPS is gone, so will lead to ptosis. Medial rectus is gone, so there will be a divergent squint. Okay. Sphincter pupillae is involved, so there will be the dilated pupil. Okay. And there will be loss of the light reflex as well as accommodation reflex, because Edinger-Westphal fibers are also being affected. So just writing down directly the features of third nerve palsy, and because it's a nerve palsy, so everything has to be ipsilateral, same side nerve. Nerve is involved, so it's a ipsilateral, everything is ipsilateral here. Ptosis. There will be divergent squint, ipsilateral ptosis, divergent squint, eyeball will be down and out, that's what we say. There will be ipsilateral dilated pupil. There will be loss of accommodation as well as light reflex. Ipsilateral ptosis, divergent squint, ipsilateral dilated pupil, and ipsilateral loss of accommodation and light reflex will be there. And it's all ipsilateral. Afferent pathway is still working, but efferent is not working. So if I still try to, looking at all these features, and as I said, we can add more to this. If you look at all these features of the Benedict syndrome, and we'll try to squeeze in even further. So the important thing involved here to understand here is that there is a ipsilateral third nerve palsy, and there is a pain and temperature loss on the other half of the body, including face. I mean, one thing which will help you remember this syndrome together. If somebody is having a Benedict syndrome, that means they will be having ipsilateral third nerve palsy. So let's say there's a right third nerve palsy is there, and there is a contralateral loss of pain and temperature from everywhere, from the face and from the rest of the body also. Right? Contralateral loss of pain and temperature of body and face, and ipsilateral third nerve palsy. And you will see how contrasting this will be with the Weber syndrome. If you look at the structures involved in Weber syndrome, once again there is let me write it here. There is involvement of third nerve. So I don't have to write that. So we have the same features of third nerve palsy, ipsilateral ptosis and everything. And the two other important structures involved there are upper motor neuron of facial nerve. Upper motor neuron of facial nerve are gone. And pyramidal tract is also affected. Isn't it? That syndrome was affecting the medial part of cerebral peduncle and middle part of cerebral peduncle, involving pyramidal tract and upper motor neuron of facial nerve. Well, upper motor neuron lesion of facial nerve, guys, what was the issue? If there is an upper motor neuron lesion of facial nerve, we know that there will be a contralateral paralysis of lower half of face. We discussed that in facial nerve. Contralateral paralysis of lower half of face, or lower part of face, it's more than half actually. And pyramidal tract, obviously if the pyramidal tract on the right side is affected, which is going to decussate in lower medulla and then supply the other half of body. So injury on the right side, the effect will be on the left side. So will lead to what? Will lead to contralateral hemiplegia. Will lead to contralateral hemiplegia. The injury is so high in the midbrain only, so that it has to come down and then supply the upper limb, lower limb muscle of the other side. So there is a complete paralysis on the other side of the upper limb and lower limb. So it's a contralateral hemiplegia. And that gives me a very good comparison here. Benedict's and Weber syndrome. What is the common thing between the two? The common thing between the two is third nerve. So just imagine a case, a patient is having third nerve palsy of the right side. So let's say if you imagine on me, there's a third nerve palsy of the right side. So I got to see what is happening on the left side here. If on the left side there is a pain and temperature loss from everywhere, from the face and rest of the body, it has got to be Benedict syndrome. But if it is not a sensory loss, if there is a paralysis of the facial muscle and hemiplegia on the other side, then it is a Weber syndrome. So ipsilateral third nerve palsy with what is happening to the other side of body. Is it a sensory loss or is it a motor loss? We'll tell you about whether it is a Benedict syndrome or it is a Weber syndrome, right? Okay. Next, we move on to the syndromes of the pons, the Pontine syndrome. So when you look at the transverse section of the pons, again, let's look at the relevant structures here. Here is the transverse section. The very much basilar part of the pons, the basilar part is the one which is toward the basilar artery. That means the anterior part. So this lower part is the anterior part here, and you will see the pyramidal tract over there. That again is the pyramidal tract. So this here is a basilar part. If I just draw this line here, there is a basilar part from where you see loads of fibers are running transversely to go into the cerebellar peduncle and reach the cerebellum. And the most important nuclei which I need to show here, well, I guess I don't have to worry too much about it. All I need to do is this, and you can identify what are these. What nerve is that? That is the, of course, facial nerve. Winding around what nucleus? Winding around the sixth nucleus. And that is the sixth nucleus, and that's the sixth nerve will be coming out like this. Sixth nerve, and that is the seventh nerve. And let me remind you something. When we saw how cranial nerves are coming from the the brainstem, then we saw sixth nerve was very close to midline from ponto-pyramidal junction. Seventh was ponto-olivary junction. And the next nerve in the same line is what? Eighth nerve. So if you're looking at sixth nerve here and seventh nerve here, so there are obviously very good possibility of looking at what nerve as well? The eighth nerve will be more laterally placed here. Sixth, seventh and eighth, the three nerve which are coming from ponto-medullary junction. Which give me the answer to the next important thing. If you're looking at sixth, seventh and eighth nerve, that means section of this pons is close to pontomedullary junction. Right now we are considering it close to pontomedullary junction, right? And if the section is close to pontomedullary junction, guys, out of three cerebellar peduncle, which two will be seen? We said superior peduncle comes down, inferior peduncle goes up and meet with middle, and all three together goes inside. Now, if you're taking a section of pons, but not in the upper part, in the lower part of the pons. So obviously pons ka peduncle is middle peduncle. So you definitely will see middle peduncle here. But along with that, you'll also see the inferior peduncle because section is close to lower part, pontomedullary junction, which is evident from these three nerves, 6th, 7th and 8th. So three peduncles, out of three, the two will be seen here. One is the inferior cerebellar peduncle and middle cerebellar peduncle will be seen. Superior will not be seen at this level. If you will see the superior, then you will see middle and superior together, then inferior won't be seen. Again, just the important thing. Again, we not drawing the trapezoid body in between and reticular formation and trigeminal nucleus. There's so many things, lemniscus and the other things also. Our purpose here is to differentiate one syndrome from another. You can always add the detail in the medicine part. Okay, so one syndrome which will be affecting the close to the midline structure, that is pyramidal tract will be gone in that, along with sixth nerve and seventh nerve also. Just make sure don't leave the seventh nerve, guys. Sixth nerve, seventh nerve and pyramidal tract. You can see this syndrome is affecting again close to the midline structures. And other syndrome we'll talk about in which again seventh nerve is involved, but this time more lateral structures. Seventh nerve will be affected in this along with the other lateral most structure of the pons. In every syndrome, if you find something common, that is a real boost to in identifying the type or differentiating the syndrome. So like in the previous case, third nerve was common in Benedict's as well as Weber's. Here, seventh nerve, both the syndrome, the seventh nerve involvement is very, very common. The syndrome I highlighted in blue here, this is another important syndrome called as the Millard-Guebler syndrome. That is Millard-Guebler syndrome. And the one in the yellow there, that is called as pontocerebellar angle syndrome. Pontocerebellar angle syndrome. See, that region, that lateral part of the pons is close. These peduncles are ultimately going into where? Into cerebellum only. So that is a region which is close to the cerebellum, more posterior laterally present. So it's a pontocerebellar angle syndrome, the posterior part here, more toward the posterior side. The angle which is taking it toward the cerebellum. So the blue one there, let me just give the same color here, Millard-Guebler syndrome. And the one I highlighted in yellow, that is a pontocerebellar angle syndrome. Well, what is a blood vessel here? That's a basilar artery. We know that in the basilar sulcus there is a basilar artery. So clearly this area will be supplied by the direct branches of basilar artery. So if there is an occlusion of basilar artery branches, that will lead to the Millard-Guebler syndrome. So the artery which is involved in this case, it is the basilar artery. But in pontocerebellar angle syndrome, the cause for the pontocerebellar angle syndrome is usually not arterial involvement, that can also be there, but because of the most common type of Schwann cell tumor. Now, what is the most common type of Schwann cell tumor in the brainstem? And that is acoustic neuroma. Acoustic neuroma is the reason mainly for this pontocerebellar angle syndrome. Acoustic neuroma. Okay, let's talk about the features. So what happens in Millard-Guebler? There is involvement of what nerve? The sixth nerve is gone there. The sixth nerve is affected. Seventh nerve is also affected. And pyramidal tract. Well, of course, pyramidal tract is also affected. Three major structures, if I talk about the three major structures. Sixth nerve involvement. Now this time, if the sixth nerve is gone, the lateral rectus muscle is paralyzed. Lateral rectus is not working, so medial rectus will take over, and that will lead to the convergent squint. So because of sixth nerve involvement, lateral rectus is gone, medial rectus is working. So this time it is ipsilateral convergent squint. Convergent squint. Seventh nerve is involved. And see, this time seventh nerve is involved. In the previous case, when we talk about Weber syndrome, it was upper motor neuron of facial nerve. This time it's not the upper motor neuron, this is the lower motor neuron. It's the nerve is involved. So seventh nerve is involved will lead to the ipsilateral facial paralysis. It's the lower motor neuron is involved. After the nucleus, the nerve is coming out and that is affected. So that is lower motor neuron palsy, and that will lead to ipsilateral facial paralysis. And still pyramidal tract is involved, just like in Weber syndrome, which still has to go down and decussate and supply the opposite half of body. So the same story here, contralateral hemiplegia. Just like Weber syndrome here, will also be the contralateral hemiplegia. Again, three major features. I keep on repeating this thing because the people do ask me later on, are these the only thing that you see in Millard-Guebler syndrome? No, other things are also affected. But when you look at all these three, they will give you a very clear-cut idea about that what will happen in Millard-Guebler syndrome, and these features are not overlapping. I mean, you cannot confuse these with anything else. Like if there is a convergent squint, let's say if I talk about in the right eye, there is a convergent squint, my abductor nerve of the right side is not working, and opposite side there is a complete paralysis, body paralysis. So contralateral hemiplegia, ipsilateral sixth nerve, ipsilateral facial paralysis, abduction of this side, facial paralysis of this side, but body paralysis of other side here. And that's why there is another name given to this syndrome, and in that name only all the three features will be counted. And the other name is, it is also called as abducent alternating hemiplegia. Abducent alternating hemiplegia. Abduction nerve is gone and hemiplegia is alternating, guys. Face paralysis of this side, but body paralysis of other side here. Face of this side, body of other side, which is unique to the syndrome. And that's why the Millard-Guebler syndrome, it is also known as alternating alternating abducent hemiplegia. Few call it abducent alternating hemiplegia or alternating abducent hemiplegia, same thing only. Alternating abducent hemiplegia or abducent alternating hemiplegia. What about pontocerebellar angle, acoustic neuroma, usually involving the inferior vestibular nerve first. So eighth nerve is the one which is being affected first to be involved. In pontocerebellar angle syndrome, the difference that you see on this and that side, first the common thing in fact, facial nerve is gone here as well. So the same, ipsilateral facial paralysis will be seen. Ipsilateral facial paralysis will be seen in this acoustic neuroma or pontocerebellar angle syndrome. Then this time eighth nerve is gone. Eighth nerve is gone will lead to ipsilateral progressive deafness. And the reason I'm saying progressive deafness is because neuroma is the usual causes of neuroma. So gradually the hearing power will be lost. So it's a ipsilateral progressive deafness. And then peduncles. Middle cerebellar peduncle and inferior cerebellar peduncle are also affected. They're also affected. There's peduncle involvement, whether it is one peduncle, two peduncle, or all three peduncle. Injury to any peduncle means the connection of the cerebellum are lost. Cerebellum afferent and efferent pathway are lost. Cerebellum, which is responsible for the coordination of the movement, if coordination will not be there properly, so that will lead to ataxia. And unlike cerebrum, cerebellum controls the same side of the body. If the right side cerebellar peduncles are gone, so the ataxia will be of the same side only. So peduncle involvement, as I said, whether one, two, or all three, it leads to the ipsilateral ataxia. The severity may vary, whether it's a very severe ataxia is there or just a mild ataxia. Dystaxia, we call it mild ataxia. That depends upon how much fibers are involved, how many peduncles are involved. But yeah, still it is ataxia. And it's all ipsilateral. It's all ipsilateral. Ipsilateral facial paralysis, progressive deafness, ipsilateral ataxia. So this is about the Pontine syndrome. And very lastly, let us now move on to the medullary syndrome. Let's talk about the two medullary syndromes. See, whatever we discussed in the past is all helping in here. Knowing about these cranial nerves and nuclei, lemniscus and peduncles, whatever we just kind of just putting all the information together. When you look at the section of medulla oblongata, the section looks roughly like a butterfly. I mean, if you look at, there are the peduncles which are forming this huge elevation posterolaterally. Then we have an inferior olivary nucleus. There is another elevation. And then we have pyramidal tract forming pyramid. That's another elevation here. So three elevations are to be seen, out of which two we already discussed. Pyramid and olive, we saw it was seen from the anterior aspect of the brainstem. This here is the pyramid. These are the pyramids here, pyramidal tract. And here is the olive, and we already said olive is because of the inferior olivary nucleus. These crumbled paper-like nucleus, if you just crumble paper or crumbled bag-like nucleus we have similar sort of nucleus in the cerebellum also. Similar shaped nucleus in cerebellum also, called as dentate nucleus. But these are inferior olivary nucleus. And the peduncle that you see on the posterior lateral side, this huge peduncle on the posterior lateral side, is inferior cerebellar peduncle. Inferior cerebellar peduncle. This is olive. That is pyramid. And here is the midline. Okay. Now, if I draw a nucleus here and the nerve, now by looking at where the nerve is coming out from, I hope you can identify the nerve as well, guys. If you look at the nerve emerging out like this, so what according to you this nerve is? Now see where it is coming out from. The nerve is coming out between what and what? Between pyramid and olive. And we already said that the only nerve coming out between pyramid and olive is the hypoglossal. So that's the 12th nerve, and that's the only nerve which emerges between pyramid and olive. And let's say close to the midline, we have these lemniscus, which are called as medial lemniscus. It's very close to the midline, so these are the medial lemniscus you're looking at. Again, just looking at the important or relevant structures, something which is situated more toward the lateral side here. And think about the medulla oblongata, what you expect to see in medulla oblongata, like nucleus ambiguous, dorsal nucleus of vagus, vestibular nuclei. Which lemniscus will be toward the lateral side? I mean, there is no auditory pathway. Auditory pathway starts from pons to medullary junction and goes above. So, which lemniscus will be toward the lateral side here? Spinal lemniscus. We have a big trigeminal nucleus having 3 parts. Mesencephalic, principal sensory, and spinal nucleus. This is medulla oblongata. So, you will be seeing the spinal nucleus of trigeminal nerve. Again, as I said, looking at the relevant structures, what we have in this region, it's a site for the vestibular nuclei. We have vestibular nuclei here. We've got a nucleus ambiguous, huge nucleus ambiguous. Common nucleus for 9th, 10th and 11th now of SVE column, nucleus ambiguous. And if I just take 2 more relevant thing, well, one is the spinal nucleus. Now look at this. It's a spinal nucleus of trigeminal nerve, mesencephalic and all that. So spinal nucleus, we're talking about the caudal part of that big trigeminal nucleus. And if I say lemniscus, the lemniscus here is a spinal lemniscus present. These relations may not be correct here. I mean, doesn't matter. I'm just looking at the structures toward the lateral side. Don't bother too much about their location. The 2 syndrome will be looking in this region. In one, the midline structures are involved, like hypoglossal nerve, medial lemniscus, along with the pyramidal tract involvement. So this syndrome will be called as a medial medullary syndrome, because structures close to the midline are involved. So we call it medial medullary syndrome. And the other syndrome we'll talk about is the one in which the lateral structures are affected here. The lateral structures are affected here. Whatever we drew on this side, the cerebellar peduncle, vestibular nuclei, nucleus ambiguous, spinal nucleus, and spinal lemniscus. This syndrome is very much toward the lateral side. So it's a lateral medullary syndrome, or better called as Wallenberg syndrome. So let's talk about these 2 syndromes. Let me write the name first. The one which is toward the medial side, that is medial medullary. Medial medullary syndrome. And one in the blue there, that is the lateral medullary syndrome. That's toward the lateral side, lateral medullary, also referred as Wallenberg syndrome. See, if you talk about what blood vessels are affected in the medial and lateral medullary, this medial part, midline part of the, medulla oblongata is supplied by the anterior spinal artery. We'll see that in the blood supply part. They're supplied by the anterior spinal artery. But it is also getting a direct branch from vertebral artery also. And vertebral artery is supplying it more heavily. So, vertebral artery and branch of vertebral artery, which is called as anterior spinal artery, is supplying it. Vertebral artery is supplying it directly also. And why it's one of the branch, anterior spinal artery. We'll see that in the blood supply part later. So, but if you have to choose one, your vertebral artery will be a better answer, because the major contribution is coming from those direct branches of the vertebral artery. Vertebral artery, so the stroke of vertebral artery lead to the medial medullary syndrome. And in case of lateral medullary syndrome, another branch of vertebral artery here, but that is pica, posterior inferior cerebellar artery. The pica, posterior inferior cerebellar artery involvement lead to the Wallenberg syndrome. In medial medullary syndrome, the important structure that we saw affected there, one lemniscus, that is medial lemniscus. Nerve, hypoglossal nerve coming out between pyramid and olive, so hypoglossal nerve was gone. And once again, pyramid. Till the time you keep calling it pyramid, that means it is above the decussation. So it still will lead to contralateral hemiplegia only. Medial lemniscus, guys, same story. Contralateral loss of conscious proprioception and other things which are related to dorsal column tract and anterior spinothalamic tract. We know that. Contralateral loss of conscious proprioception, touch, vibration, stereognosis. Hypoglossal nerve involvement. Again, nerve involvement. Hypoglossal nerve involvement will lead to ipsilateral tongue paralysis. Ipsilateral tongue paralysis. Ipsilateral tongue paralysis. Hypoglossal nerve involvement, ipsilateral tongue paralysis. The thing is, ipsilateral tongue paralysis, in this case, the tongue deviates toward the side of the lesion. I mean, usually what happens is, if there is an injury to some muscle, the dominant side will take over and the deviation is seen on the other side. If I say biceps and triceps, if my triceps is not working, so my elbow will go into flexion. Elbow will go into flexion because biceps is working but triceps is not working. But in case of tongue, it is different. In hypoglossal nerve injury, the tongue deviates to the same side of the lesion. Well, why it is so? Now, there is a muscle called as genioglossus supplied by hypoglossal nerve, and we have two genioglossus. So we have right and left genioglossus. When both the side genioglossus they work together, the tongue will come out straight like this. So genioglossus both sides working out and tongue will come out straight. But imagine if there is a right hypoglossal nerve injury. So this genioglossus will not work, the right one will not work. Now if I protrude the tongue now, I will be using only one genioglossus. So the left side of the tongue will come out, the left mass of the tongue will come out, and that will deviate the tip toward the other side here. Because the left mass of the tongue is coming out, that will deviate the tip toward the ipsilateral side. Because the right side of tongue is not coming out, genioglossus of the same side is not working. So it is important when you say in hypoglossal nerve injury, the tongue deviates to the same side of lesion, well, only when you ask the patient to protrude the tongue. If you just ask the patient to open the mouth and show the tongue, you will not see deviation there. When you ask him to protrude, then only you will see the action of the other genioglossus pushing the tongue to the opposite side, to the side of the lesion only. So ipsilateral tongue paralysis, or you can say the tongue deviates to the side of the lesion when asked to protrude. And once again, pyramidal tract involvement will lead to contralateral hemiplegia. Same story, contralateral hemiplegia. So what is the uniqueness in this syndrome here? The tongue of one side, but body paralysis of other side here. Very unique. No other syndrome will have the same. We have a ipsilateral tongue paralysis, but contralateral hemiplegia. So if I am having a left side hemiplegia, the tongue, if you ask me to protrude the tongue, my tongue will protrude toward the right side, because that's what the hypoglossal nerve property is. Ipsilateral tongue paralysis, contralateral hemiplegia. And very lastly, Wallenberg syndrome. Now we wrote many structures involved in Wallenberg syndrome. There are in fact more than that. But if I just focus on to them, first thing is ICP, inferior cerebellar peduncle. Guys, involvement of inferior cerebellar peduncle once again will lead to ipsilateral ataxia. One peduncle, two or all peduncle, ataxia. Then what? There is involvement of the vestibular nuclei. Vestibular nucleus involvement, vestibular nucleus involvement will lead to what? Nystagmus, and there will be the giddiness will be there, and vertigo. So all that vertigo, vomiting, etc. Then we also talked about the nucleus ambiguous involvement. Well, we talked about the nucleus ambiguous injury in the cranial nerves only, or cranial nerve nuclei. because nucleus ambiguus is giving off the fibers to 9th, 10th and 11th nerve. So involvement of nucleus ambiguus means there will be 9th, 10th, 11th nerve is gone. The muscles of palate are gone. Muscles of pharynx are gone. And muscles of larynx are also gone of the same side. So there will be ipsilateral bulbar paralysis. Although tongue muscle will be spared, but still we call it ipsilateral bulbar paralysis. And 9th and 10th nerve are responsible for gag reflex also. That also will be affected. So it will lead to the ipsilateral bulbar paralysis. Ipsilateral bulbar paralysis and loss of gag reflex. Then we said spinal lemniscus. Spinal lemniscus is found by the lateral spinothalamic tract. Lemniscus injury means contralateral, so there will be a contralateral loss of pain and temperature from where? From the body. Contralateral loss of pain and temperature from the body. Spinal lemniscus involvement will lead to contralateral loss of pain and temperature from the body. And coming to the most important thing, we also said spinal nucleus. Now just to remind you guys, spinal nucleus was this one. The trigeminal nuclei, and this part was a spinal nucleus. This part was a spinal nucleus, which is in medulla oblongata. So this part is affected. And spinal nucleus is responsible for carrying the pain and temperature from face. But because it's a nucleus injury, nerve injury or nucleus injury, the effect is on the same side, unless the injury is to lemniscus. That's why, because it is a nucleus injury and not the lemniscus, so it will lead to the ipsilateral loss of pain and temperature from where? From the face. And that's the unique thing about this syndrome, that there is a contralateral loss of pain and temperature from the rest of the body, but from the face, it's the ipsilateral loss. Ipsilateral loss of pain and temperature from the face, but contralateral loss of pain and temperature from body. Very, very unique to the Wallenberg or lateral medullary syndrome. It's very unique to the Wallenberg or lateral medullary syndrome. So this is about the syndromes of the brainstem. If I just kind of summarize the syndrome of the midline and together, so that you can see that how we can remember it easily. If I just take you back and starting from the midbrain, if you look at the midline, if I just looking at the midline part here, like Weber syndrome here, the closest to the midline here, Weber syndrome, W, that is Weber syndrome. I come down here into the pons, that is Millard-Gubler syndrome. So initially it was Weber syndrome, now it is opposite M, that is Millard-Gubler syndrome. And I go here middle, that what syndrome? The medial middle syndrome. So again M here. So all the syndrome of the midline, they are either like this, W or M. MW syndrome, they are in the midline. Just a way to remember it. Pyramidal tract involved in this. Pyramidal tract is involved in this also. Pyramidal tract is involved in this also. So all these midline syndrome is having one common feature, that pyramidal tract is involved. And then all you have to see that which nerve is involved. Contralateral hemiplegia will be there because pyramidal tract is there. But which nerve? What is a major nerve involvement here? Third nerve is involved. Which major nerve is involved here? Facial nerve is involved. Although sixth is also there, but let's remember one only. Facial nerve is involved. And what is a major nerve involved in this? The hypoglossal nerve, the three motor nerves. So if I try to write them together this way, that all these midline syndromes, if this is midbrain, pons and medulla oblongata, the three part of brainstem. So we got the Weber syndrome, we got Millard-Gubler syndrome, and we have medial medullary syndrome. So basically MW syndrome. Weber syndrome, Millard-Gubler and medial medullary. Common thing, all of them, contralateral hemiplegia. Contralateral hemiplegia. And why is it so? Because pyramidal tract is involved, all the three cases. All you have to do is see which ipsilateral cranial nerve is involved. This case, this case, this case. So it's a ipsilateral third nerve palsy in case of Weber syndrome. Ipsilateral sixth as well as seventh. Let me write both. Sixth and seventh nerve palsy in case of Millard-Gubler. and there is a ipsilateral hypoglossal nerve palsy in case of medial medullary syndrome. Imagine if you remember this, just few steps in here, you can easily differentiate all these syndromes from each other. Contralateral hemiplegia is a common thing, and you have to see which main motor nerve is involved here. Ipsilateral third nerve palsy, it has to be in the midbrain, that is Weber syndrome. Sixth and seventh nerve, they come out from the pons, so some syndrome of the pons, that is Millard-Gubler. Ipsilateral hypoglossal nerve, hypoglossal nucleus is present in the medulla oblongata, so medial medullary syndrome. So guys, this about the syndrome of the brainstem. With that, we conclude the brainstem part, and the next from the brainstem will be the cerebellum.